going to talk about pediatric toxicology and specifically single pills that can kill. There's some interesting medication classes to be aware of and things to consider. A lot of these are going to be case-based, so I'm going to ask for your input. Probably going to keep a lot of these cases intentionally vague. You'll see there are some like cases that mimic other cases and other weird things thrown in there. So just roll with it, it'll be fun. And in honor of the typical kind of like situation we run into in the field, this is named Mima's medicine cabinet for all the kids getting into grandma's meds. So learning objectives today, we're going to go over some high-risk classes of medicines, especially ones that fall into that one pill that can kill category. We're going to look at common presentations for toxic ingestions of those overdoses, and then kind of figure out what additional initial supportive treatments we can do until these kids can get to definitive care. I've got nothing to disclose. Financially, I'm a poor resident, so. All right, so a little bit of history. In 1970, the Poison Prevention Packaging Act was passed. This is what resulted in all of that child-resistant and child tampering-resistant packaging on a lot of common over-the-counter and prescription medicines, as well as like household products. Unfortunately, as you guys may be aware, that doesn't really stop kids from getting into trouble if they want to get into stuff. So this data in the next bullet points from the National Poison Data Service. So essentially, every time someone makes a call to poison control, it gets automatically uploaded into this database. From the most recent year we have on file, there were 2 million pediatric ingestions of medications that could possibly be toxic. Now you can imagine, not everyone has poison control on speed dial and is calling poison control. So I would anticipate that number is actually higher than 2 million. So this is something that happens not infrequently. The majority of these kids are young. They're under 5 years old. These are oftentimes what we call exploratory ingestions. So the kids aren't really trying to do anything. They just see something that looks like candy or something else interesting. They put it in their mouth. But unfortunately for some of these medications, especially the kind of one pill that can kill category, that can be a pretty major mistake. So of all of the medications that account for these ingestions, opioids and over-the-counter medications are by far the most common and contribute to mortality. We're going to talk about some weirder things that don't fall into that category too, but just for your background knowledge. And then a lot of these medications also have what we would term a narrow therapeutic window. So the idea of a therapeutic window is how much leeway do you have in terms of dosing in order to get a beneficial therapeutic expected effect of a medication. So something that has a very wide therapeutic dose, you could take 1 pill, maybe you could take 5 pills, you're still going to be having those beneficial effects. Something with a narrow therapeutic window, you misdose it by a tiny amount and you might be running into toxicity or overdose or bad side effects. All right, so I have a graph here on the left side of your screen. This is from the U.S. Product Safety Commission, which is kind of the independent federal organization that looks at a lot of accidental ingestions from household products, and we're the ones that kind of spearheaded that tamper-proof packaging back in the 70s. You can see along the x-axis, so the horizontal axis is time, and then along the y-axis is not only looking at pediatric ingestions, but pediatric ingestions that resulted in death. So after 1970, that dropped pretty precipitously and stayed low for a while. And then unfortunately, after 2020, there's been a spike. For one of the more recent years we have on file, the agency was able to break down those lethal ingestions by what type of medication was ingested. And the only thing I want to point out here is that a high proportion of them were opioid medications, so something to be aware of. Okay, who's heard of toxidromes? Okay, so toxidrome is the word we kind of use to describe a constellation of symptoms, physical exam findings, and physiologic changes that a patient experiences when they consume one type of drug in overdose or adverse effect. So someone give me an example. If we pick up somebody with opioid overdose, what kind of things are you seeing with them? And you can cheat, it's right here on the screen too. Yeah, pinpoint pupils, what else?
Decreased respiratory tract.
Yeah, respiratory depression, that's a huge one. What else? Yeah, exactly. Everything's kind of down, right? Similarly, like if we look at the sympathomimetic line, second to the bottom, that's our toxic ingestions, things like methamphetamines, cocaine. We kind of see the opposite, right? Those patients are diaphoretic, they've got dilated pupils, they're a little bit agitated, they're super tachycardic, can be hyperthermic. And so these are nice mental shortcuts we can use to help us decide how to best take care of patients if we're concerned about some sort of ingestion. As we're going to see today, this doesn't always hold true. There are certain agents that mimic toxidromes. There are certain agents that don't fall neatly into one category or another. So I still think looking at pupils, looking at a patient's skin, looking at their vitals at the end of the day is still going to be super important. Just know, kind of keep in the back of your head, things aren't always going to fit into neat categories. So with that, we often have to do a little bit more investigation. So oftentimes we're working, especially you guys are working in the field with very, very limited information. If possible, and you get called out for ingestion, you might want to think about some things like, are there pill bottles on the scene? If there is a pill bottle, what is it? How many pills are left in that bottle? Can you guys think of any other information that might be useful?
Dosages of it.
Yeah, doses of medication.
When it was filled.
When it was filled. If we don't have the label, maybe a description of the pills. Did anybody witness it? What time was the medication ingested? For things like Tylenol poisoning, that can be really important for initiation of treatment. Vomiting.
We have the vomit and the pills from vomit.
Yeah, exactly. What do you see, smell, hear, right? What medications does the patient have access to? Maybe the patient, especially these pediatric populations, maybe they aren't prescribed anything. Maybe they're an otherwise healthy kid, but what's in the medicine cabinet? What could they possibly have gotten into? And then for older kids, teens, was this a suicide attempt? Do they have suicidal ideation? That's important for once they get admitted to the hospital so psychiatry can connect with them, keep them safe. All right, yeah, go ahead.
The graph you were showing,
yes, sir.
What age was that up to?
That's a good question. I'm not sure off the top of my head. I believe it was under 16, but I'll look into it.
Okay.
Yeah.
So do you think suicidal ideation had anything to do with the uptick in the pandemic? Or?
It's possible. Like I said, probably for teenagers. I don't think, I'll have to review the report again because they did break it down several ways. I'm not sure if they broke it down into age cohorts, but that would be certainly an interesting analysis to do. Like if the older kids or teens, if a large percentage of those ingestions were suicidal attempts rather than the exploratory ingestions. But still, I think overall, the exploratory ingestions make up a vast majority of these accidental ingestions. All right, yeah.
Just to piggyback on him real quick, I just thought it. Do you think that increase, not only from a suicidal standpoint for the older population in that, but could it possibly be also from a lot of the like TikTok challenges and stuff like that that have permeated?
Yeah, unfortunately, I don't have any data on it, but I wouldn't be surprised if social media plays into it. I know our toxicologists were working through, here at Prisma, working through all the Tide Pod challenge craze and all of that stuff online where kids would, for on a dare or for social cred or whatever, ingest all sorts of weird stuff. They have to support them through. So yeah, unfortunately, that's reality. Yeah. So what I'm going to propose today is ABCs, E and G. So I'm adding an E and G to our ABCs. It stands for EKG and glucose. If you have all those pieces of information and you support weird derangements or abnormalities with ABCs, EKG, and glucose, then you can get patients through 90% of the supportive care they need until they get to definitive treatment in the hospital. If there's an antidote available, great, let's give it. More often than not, there's not an antidote available. So it's more of supporting ABCs, E and G until we get them to definitive care. So with that, let's go into our first case, little candies.
Are you talking about like give them D10 as like a fluid choice, D5?
Correct, and we'll get into that as the cases go through and you see where it becomes relevant. Yeah. So your guys' first call for a 4-year-old male, there are his vitals. He says, I found some little candies, they tasted bad. Yes, grandma, she says, my blood pressure medicine bottle was open, but there's only 1 pill missing, so no worries. Okay, what are our initial thoughts?
Which blood pressure medication?
Grandma doesn't remember.
It's probably a beta blocker. They're common. You've got the crazy heart rate potentially.
Good, yeah, so tell me what you're noticing about this kid's vital signs.
Pressure's fine.
Uh-huh.
Heart rate's a little low. Respiratory rate's a touch low, but not really worried about it. BGL,
Yeah.
not really worried about 140.
What if grandma tells you he hasn't had anything to eat today? Otherwise healthy kid.
Okay, a little concerning. Been a long time.
A little weird. So yeah, maybe like borderline low vital signs, but otherwise stable. You look at the kid and he's looking all right. No like real symptoms. He's not vomiting. He's not pale or diaphoretic. He's kind of playing on his own. So I think your idea with beta blockers is right on. This one is going to actually be a calcium channel blocker. So this is nifedipine overdose. Does anyone know what those dark blue pills on the screen are?
After Google, I would.
There you go. Diltiazem.
Carson.
What about the round pills on the edge of the screen? Any guesses? They're all diltiazem. That's the spoiler here. So just to show things can look different. I have to look up pills all the time just because there's so many different formulations, so many different capsules and tablet forms that can come in. So beta blockers and calcium channel blockers, these are blood pressure medicines. These are our alols or our penes. I've highlighted some particular examples in red: diltiazem, verapamil, nifedipine, propranolol, sotalol, because these are all particularly dangerous. The first 3 all fall into that category of single pills that can kill. So the point of this case was, the 4-year-old took 1 of grandma's nifedipines. That could be enough to kill him, unfortunately. So something that we have to have a high threshold of suspicion for if there's any concern for. Maybe we don't know the exact agent. Maybe we know, hey, a little kid got into blood pressure medication. Propranolol and sotalol I throw up on here because they have some weird complications that are important to be aware of. Propranolol, so they're both non-selective beta blockers. Propranolol has this weird tendency to cross the blood-brain barrier, and in little kids it can precipitate seizures. So you might get called out for an ingestion without initially knowing it's an ingestion. Maybe get called out as a seizure for a little kid. And all you got to throw in is one more wrench into the works. Like let's say the kid had a cold recently. This maybe has a little bit higher temperature. And you might be thinking, oh, this is a exactly uncomplicated febrile seizure, when in reality it's a toxic ingestion. So things to be aware of. Sotalol has some activity with blocking potassium channels, some antiarrhythmic activity, which can actually precipitate arrhythmias in these kids, including torsades. So that's something to be aware of with that agent. So in terms of mechanism, it's all in the name. Beta blockers block beta adrenergic receptors, calcium channel blockers block calcium channels. The end result, when it's used correctly in adults, is smooth muscle relaxation for blood pressure reduction. But as you can imagine, with these kids, it can have adverse effects. So most likely what you're going to see is everything's down, right? Bradycardic, hypotensive. It's just going to lower and tank these kids. One notable thing I think is kind of interesting, and I tried to illustrate with this case, is the one difference you'll see between beta blocker overdose and calcium channel blocker overdose is the BGL. So you can get hypoglycemia with all these beta blocker overdoses, but with calcium channels, you can actually see hyperglycemia. So again, if the kid just ate a pack of Skittles, it's really easy to ignore that BGL. In the right context, though, it might be important, just an extra clue to be aware of. So in terms of initial treatment, again, always go back to ABCs. So for hypotension, you can give crystalloid, 10 to 20 cc per kg bolus. For hypoglycemia, give glucose. For calcium channel blockers, you can give calcium. The idea is flood those calcium channels with calcium and outcompete the drug. And then if you've got hypotension refractory to crystalloid, then consider pressors for these kids because you want to support their hemodynamics. Atropine won't help for bradycardia. Any ideas why?
At least in the calcium channel, it's not the parasympathetic nervous system that's causing it.
Right, exactly. We're looking at smooth muscle relaxation and vasodilation. It's going to be less having to do with the AV node itself and more with that smooth muscle. So we'll get into some other categories of medications where it'll be more helpful, but here it's probably not going to do a whole lot. All right, so let's say you're rolling along, you check the kid, boom, those are your vitals now. Kid looks super pale, probably looks something like this, not great.
He aged.
He also aged about 50 years, yeah. What are we gonna do? Yeah, I love that. Yeah, put the pads on. What else? Yeah, pressors, let's do it. So I'm going to talk about something that you guys are going to get access to next year, which is push dose pediatric epi. So this will help centrally, giving their heart some extra squeeze, help with that bradycardia, help with their blood pressure, and is an easy way to help temporize them long enough to get to the hospital. So dose for push dose pediatric epi is 1 mic per kilo. So there are a couple ways to do this. I'll show you guys one way, and then there's an even easier way. So one way to do it is to drop the kid's dose of code epi and then put it in 10 c's of normal saline. So for example, in a 16-kilo child, which is approximately how much this 4-year-old would weigh, you drop 1.6 mils of the code epi, put it in 10 cc's, and then you've got their dose per mil, 16 mics per mil, and you'd give 1 mil at a time. Another kind of standardized, even easier way to do this is to take 1 mil of code dose epi and put it in 9 mils of normal saline for a total of 10 mils. And then you've got a syringe that's a standard 10 mics per mil. And then whatever that kid's dose is, you can give it. But then you've got a standard push dose pediatric epi stick with you. All right, questions about this case? All right, let's move on. Case 2, dig in for clues. We've got some trouble in the sandbox here. You got a 6-year-old who got called out. These are her vital signs. That's the only vital signs we have access to right now. And Grandma says, I think she got into something in my purse. What do you guys want to know?
What's in the purse?
Oh, I have some heart medication I take.
What do you take it for?
I've, the doctor told me I had heart failure. I've been taking it for like 30, 40 years. I've been on it forever. It's no big deal. I heard something about heart rate. What are we concerned about with this kid? Yeah, bradycardic for that age. That's not good. You want to know what the kid looks like? Sweaty, pale. You try to stand her up, she gets super wobbly and lightheaded. You throw her on some leads. You get that briefly. You're like, huh?
I need an adult. You're an adult.
That doesn't look right. You get the 12 lead, and briefly you could swear just for a second. You see something like that. You're like, okay, yeah, that really doesn't look right. Any ideas what this is? So this is digoxin. So digoxin, it's also found in the plants that I've listed up there. Some of these, including oleander, are pretty common. Like you'll see them around. So something to be aware of, especially for like really little kids who might eat plants accidentally. All of those have analogs of digoxin, very similar drugs in them, as kind of like active chemicals in the leaves and parts of the plant. So it's a heart failure medication. It makes the heart squeeze harder. The way it does that is by blocking these sodium-potassium ATP channels. The kind of net effect and not to bore you with all the biochemistry, is that you get more calcium in your heart, which triggers the heart to squeeze harder. So in somebody with heart failure, you can see how it'd be useful if they've got a reduced ejection fraction, if their heart's not squeezing like it should be. In kids, a little scarier. So they can...
In theory, you're
Yes.
tilting the scale of your electrolytes.
Yeah, exactly. And that's a really good observation, because a lot of that's going to be important with these toxic ingestions. You're going to see weird electrolyte derangements, which can cause a lot of weird bradycardias, bradyarrhythmias. These kids could present with syncope, nausea, vomiting, altered mental status. With the EKG, you can see pretty much anything. You can see anything from PVCs all the way up to bidirectional VTEC, which was that 12 lead I showed on the last slide. I'll give you guys another look at it in just a second here. But to your point, you can get weird electrolyte derangements, in particular hyperkalemia, so increased potassium from blocking these channels is especially dangerous. Yeah, go ahead.
If it's blocking the potassium, how can you get hyper K?
So the way the channel works is one ion goes into the cell, one ion goes out of the cell. So if normally it imports potassium into the cell and you block it, then potassium starts building up outside of the cells.
Okay.
Yeah. So here's that bidirectional ventricular tachycardia, which is pathognomonic for digoxin toxicity. It's kind of rare. You won't always see this, but if you do see it, think of digoxin. I think the easiest place to look at it is on the rhythm strip at the bottom. You can see alternating QRSs, the axis. You can also get things like this. Anyone want to tell me what they're seeing on this EKG? Yeah, T waves all day. Those are some huge T waves. So this is a patient where you might be concerned, like, hey, hyper K. What would you guys do for peak T waves if you saw this? Yeah. I hear some muttering. You guys can speak up. It's okay. They're all great ideas. Yeah, exactly. I love it. So I would just throw everything you have at these kids if you have any concern for hyper K. If you're doing albuterol, throw them on a long treatment. Do like 10 milligrams. Give the calcium to stabilize cardiac membranes. The reason being is with digoxin specifically, mortality directly correlates to their presenting potassium level. So again, with these kids, the mortality rate correlates to the initial potassium level, and it's fairly low. If I'm not mistaken, I believe something like potassium over 5.5, which is not too far off of a normal potassium, with digoxin toxicity is close to like 100% mortality in these kids.
So how are y'all reversing this?
Yeah, so we're going to get to that right now. So Digifab. Digifab is a drug that is made from an antibody. So they essentially engineer a fragment of an antibody to bind to the drug. And so if anybody is unstable or we're really concerned about them, they're hyperkalemic, they can get this Digifab and it'll just bind up and soak up all that drug. But until they get there, we need to support them. Basically, again, go back to your ABCs. If you've got hyper K signs on your EKG, treat that. You can give atropine for bradycardia. And then lastly, I threw on here avoid cardioversion. Any thoughts why? Yeah, exactly. So you've got an ion problem. It's precipitating weird arrhythmias already. If you try to cardiovert these kids, it can actually precipitate VFib. So.
Do you have the increase with the cardioversion because of the multi-directional VT? Do you have, are you running the risk of more likely having the R on T and driving them into that?
That's a great question. So as far as I'm aware, the recommendation is like if you're stuck in your position where you absolutely have to, you would actually start with lower energy because of the existing electrolyte derangements. You go as low joules as you can to avoid precipitating a different dysrhythmia.
So if you're in that bidirectional VTAC, why not amio, lidocaine?
Yeah,
or-
you can.
Okay.
Yeah. Follow your protocols. All right, case 3, minty fresh breath. This one, you guys are getting a call for an older kid. He's 15. There are his vitals. What do you guys think about vitals? Yeah.
He's septic.
Well, and to your point, like, hey, maybe this could easily mimic a sepsis patient. Again, like, what if he also happens to have a cough with the fever? Like, how many of you are thinking sepsis? I might, you know. All he says is, hey, I'm going on my first date today. I drank some minty stuff I found in the cabinet, and now I don't feel great.
It's alcohol. Okay, whatever.
He's got a fever. You get on scene, he's tripoding, he's breathing like faster than 32 times a minute. He's now 40, 45. He looks sweaty, he's vomiting. He looks pretty sick.
Did he drink mouthwash?
No mouthwash in the house.
So we don't
No mouthwash in the house anymore? What is it?
Yeah, do we have the bottle or whatever you drink?
Yeah, so you do a little bit of investigation. You look into, good thought, no NyQuil in the house either. You go into the medicine cabinet, and on the bathroom sink, there's a big bottle of oil of wintergreen. Anyone ever heard of this stuff? Okay, so it's available over the counter. It's often marketed as like an essential oil, something for like holistic therapy of whatever symptom you're having. And it smells really minty. But actually what it is a salicylate. So it's essentially aspirin, but super, super concentrated. So aspirin, you can find salicylates in Goody powder, Pepto-Bismol, you can find salicylates, and then this oil of wintergreen is pretty much all salicylates. The thing with it though is it's extremely, extremely concentrated. So a toxic dose for this 15-year-old of this stuff is 5 mils. That's it. For a 15-year-old. So imagine if a toddler gets into this, it's minuscule amounts. They can get a super toxic dose. So how do salicylates work in overdose? They essentially uncouple oxidative phosphorylation, which is a fancy way of saying they block the endpoints of metabolism and prevent the body from using ATP, the energy molecule. So your body normally takes glucose, takes some energy, it metabolizes it. At the very end, it goes through this chain of proteins called the electron transport chain, and the end result is ATP, the energy molecule. This blocks that process. So the body tries to keep up by using all sorts of other weird forms of metabolism, like lactic acidosis.
Are you supposed to drink it, or is it like something you use like an essential oil?
So you're supposed to use it as an essential oil, but I'm going to show you guys at the end of this case another product I found online after like 2 minutes of Googling that was marketed as something that you ingest. So both, I guess, is the answer.
So I mean, ultimately, you're running into anaerobic metabolism.
Correct.
Same as septic shock.
Similar. So yeah, you have an increased metabolic rate, which is why these kids are tachypnic. You get profound acidosis. So they can be tachypnic, they're hyperthermic, they can be vomiting. If they're altered mental status is kind of like the salicylate equivalent for what correlates with mortality. If someone has had salicylates and they're altered, that's a bad sign. And then the kind of like buzzword you'll hear is tinnitus or ear ringing, which can happen with salicylate toxicity, but it doesn't always, so don't bank on that. The reason why they're so tachypnic is because with these alternative pathways for metabolism, they get really acidotic. And so the way they compensate with that is by breathing really hard to blow off all that carbon dioxide. So can you guys think of anything you might want to avoid with these patients, given that they're acidotic and trying to blow off as much CO2 as they can? Aspirin, yes. What else? What about like sedatives? Anything that would cause respiratory depression, right? Because they're breathing hard for a reason. They're trying to blow off all that CO2. And then same thing goes with intubation. You know, at the end of the day, ABCs are ABCs. So if you have to, you have to. But if you can't avoid intubating these kids, it's better to avoid intubating them, because you're gonna have to crank the respiratory rate so high up on the vent to keep up with what they're naturally doing to prevent themselves from being more acidotic. And that's especially a problem.
Bi-level?
You could consider that, yeah, if it helps them blow off.
So when you talk about being on the vent, crank it, are you getting more like into like the ARDS type situation where you might be 40, 45 a minute, but like low?
Right.
Super low volume?
Right, but even in that case, it's just gonna be hard to get enough tidal volume at a fast enough rate to keep up with the acidosis. Because oftentimes it's like they'll be tachypnic, but they won't be shallow breathing tachypnic. They'll be these deep kind of tachypnic breaths. And the problem is,
Kuzma, yeah.
Similar to Kussmaul, yeah. And the problem with all this is salicylates can actually change form and become either ionized or unionized based on how much acid is in your blood and how acidic everything is in your body. So if you get more acidic, it changes into a form that can cross the blood-brain barrier. And then you've got salicylates in the brain, and then you're more acidotic. So you can imagine if somebody's altered, you intubate them and they get more acidic, then more, and we're not able to keep up with the vent, then more is crossing the blood-brain barrier, and it's just this vicious cycle that worsens and worsens and worsens and worsens. You can get some weird stuff with this too. So on my initial treatment algorithm here, I have given LR. Any ideas why I'd give LR over saline in these folks? Yeah, exactly. So saline's got a pH of 5 point something. It's pretty acidic. So if you have LR, give it to support hypotension. Bicarb, why would we give bicarb?
They're acidotic.
Yeah, exactly. Salicylates, if you know salicylates cause acidosis, then that's all you need to know. Give bicarb. And then D50, any ideas about why we'd give sugar? Yeah, exactly, right. Right, we're relying on lactic acid production and all these things that the body shouldn't normally be using. So if we can give glucose, the normal kind of substrate for energy production, then that's fantastic. Another weird thing with these patients in particular is that you can have really, really, really low glucose in your central nervous system and in your brain, but have a normal peripheral BGL stick. So if you see one of these patients that's altered on salicylates, you do their BGL, it's like 120, and you're like, okay, they're not hypoglycemic. They still could be hypoglycemic in their brain, which can be really dangerous. So just give them sugar. There's some evidence to suggest like maybe if somebody's drank this stuff in the last hour, that you could give charcoal. You'll get a lot of different opinions on this. There's mixed evidence. Certainly if anyone's an aspiration risk, or if anybody's had another toxic substance that's caustic and they'll eventually need to have a scope down their throat, you don't want to give charcoal. But that may be an option. And then ultimately these folks are going to require dialysis at the hospital. So salicylates are a dialyzable drug. So they're probably that'll be their endpoint here. So this is what I was talking about. The other day, I went onto Walmart's website. After like 2 minutes of searching, boom, oil wintergreen. It's $3, so it's really cheap. But look what else. Flavor. So usually it's marketed as an essential oil, but you can find it as flavoring too, which is wild.
Is that the same thing?
So
It's for baking.
So this is for baking.
If you put a lot of peppermint oil in something, you're gonna.
So this is specifically wintergreen. You have to look at the ingredient label. The problem is anything that's marketed as a supplement rather than a food substance is not subject to any sort of standardized process. So you never know is the punchline. what kills me too is within the title it says extra strength flavor. So just know that it's a weird thing that's available. Exactly, and yeah, they could say extra strength, who knows? It means nothing, gobbledygook. So, all right, case 4, cutting out the sugar. This is for a 12-year-old. Those are her vitals. All she says is, I thought they were weight loss tablets. She doesn't want to tell you much else. What are you guys thinking so far? Did we notice anything with the vital signs? Okay, yeah. So tell me what kind of medications are we thinking of?
I mean, over the counter, you got niacin, stackers, all those.
Mm-hmm.
Old school weight loss drugs.
Weight loss drugs, and then I also heard a bunch of diabetes kind of medications. Are there any diabetes medications in general that we'd be more concerned about? Especially like, let's say she just took 1 tablet. What's that? Good thought. So yeah, so all great ideas. These are our oral hypoglycemics. So the medication class is sulfonylureas. Glipizide, glyburide, glimepiride, those are kind of agents you'll hear of in this category. So the way they work is they essentially just force the body to release insulin. So folks can get really hypoglycemic. The issue is that they're super long acting. So you could get anybody for ingesting this medication, they could present anywhere from asymptomatic to completely unresponsive. Maybe they took it 5 minutes ago, they have no symptoms. Maybe they took it a couple hours ago and you get a call out for unconscious, unknown cause. Because they have such delayed and prolonged hypoglycemia, it can be really dangerous and they often need frequent monitoring. And this goes back to why I like to add glucose into that ABC's algorithm we're talking about, because that might be our only clue that something else is going on here. So treatment, sugar's low, give more sugar, right? What would you guys do if somebody is confirmed that they took, like, let's say glipizide, they have the packaging, they say, oh, I thought it was something else, I accidentally took a bunch of these. You do their BGL and it's normal. Would you still give sugar?
Mm-hmm. Yeah. Hey, doc, if we're sure of what they took, then yeah.
So in this case, you'd actually want to avoid it with normal sugars. And the reason being, what happens when your body gets a bolus of sugar? Just like you eat a Snickers bar, what happens physiologically?
So you're helping push the release.
Yeah, exactly. Your body releases insulin to take care of all that sugar, right? So you could run into a situation if somebody is normoglycemic and you give sugar where you're just forcing the body to release extra insulin and then the drug works later. So what's kind of tricky about these particular drugs is patients will have recurrent hypoglycemia and they basically have to be monitored in the hospital for days where they'll do regular BGL checks and just wait for them to get hypoglycemic, give them sugar to bump them up into a safe range, and then just wait and repeat that cycle for as long as it takes for the patient to metabolize the drug. As you can imagine, it's kind of a scary situation to be in. Nobody likes waiting for their patient to get hypoglycemic, especially if you know it's going to happen in the future. But if their BGL is normal, you can hold off on sugar. But these are patients where if you even have a suspicion for it, repeat BGL checks, not a bad idea. Wait for them to get hypoglycemic, give sugar. There are a couple other adjuncts you can give too. So glucagon you can give. That'll kind of temporize them. And then octreotide, that'll suppress the body's release of insulin. That's another agent that's actually been pretty well studied to prevent specifically rebound episodes of hypoglycemia after the first instance, which is important because these agents are such long-acting agents.
You combine B10 and glucagon, you have to?
Yeah. Yeah.
Is this in our protocols? Can we do it for this kind of hypoglycemia?
It's a great question. Yeah. Cool.
Yeah, I mean, you're saying like you're gonna recheck
sugars, and then if they're hypoglycemic, then
Yeah.
treat them.
Sugar's low, treat it.
Yeah, we just have D10. So.
And so, again, like all these are kind of notable examples for weird agents where, you could run into a situation where a single pill could kill the patient. But at the end of the day, don't overcomplicate it. Like if sugar's low, fix it. If they're hypotensive, fix it. If they're bradycardia, fix it. And that'll get you 90% of the way there.
Understanding that they're acidotic.
Yes. And again, that's the other reason why I wanted to go over some of the classes of these medications, because having a basic understanding of, someone had salicylates, they're going to be acidotic, can really help you out and prevent the patient from getting a whole lot worse and spiraling. Especially, who knows, I mean, maybe you guys got a 45-minute transport time that you run into. You're going to be with that patient for a while. Yeah.
So if you do it differently and do it through the GI tract and do like oral glucose or like soda or something like that, because they're not really like that low, they're low, you know? So would that be different than just going straight to IV because of the way that it's going in?
So that's a good observation. So something is going to be absorbed at a different rate through oral route than through IV route. If somebody is, let's say their BGL is like 78 or something, they're not altered, you think they can tolerate anything by PO and that's what you have, then go ahead and give it. I would just be suspicious and have a low threshold to recheck things and make sure it's not getting worse and you're keeping up with it. Because you might recheck it, they might be fine, you might recheck it in another 10 minutes and then their glucose is back up, or maybe the amount of drug they ingested is enough to drop them faster than you're able to keep up with oral glucose.
But they would present that way. Like if it just magically dropped while we're transporting, then you could establish. I just don't understand why you're going to give a 12-year-old an IV for somebody that's not really like hypoglycemic. They're just like borderline.
So
why don't you just give them oral glucose? It's going to absorb differently.
Yeah.
If they've taken those.
No, you can.
Okay.
You can. I'm just saying wait until they're hypoglycemic. So you don't make the body release extra insulin because you're already anticipating that the drug's going to do that.
But doesn't it take the body hours anyways to absorb through the GI tract? So wouldn't oral glucose be better than straight IV?
You could. I mean, I'd argue that if you're waiting for somebody to be hypoglycemic and they are hypoglycemic, again, this all kind of depends on the degree of hypoglycemia. But if someone's super hypoglycemic and you want to get sugar in them fast, then IV is going to be fast. So, all right. Next one is a long nap. This is for a 2-year-old. Those are the vital signs. Any thoughts?
Heart rate's low, blood pressure's a little soft, respiratory rate very low.
Yeah.
This is probably opioids.
I'm hearing everything's down. So yeah, what toxidrome does that sound like? Opioids. All you hear on scene is, he's napping for longer than usual, I can't wake him up. What else do you want to know? And no, parents don't know the name of their medicines.
Have they tried waking?
They've tried waking him up, just really sleepy.
Has it been sick?
No recent illnesses. For the child or parents?
For the child, first off, you're just normal history.
Yeah, child is normal. Parents both have history of hypertension and opioid use in recovery, and they're taking something for it. They don't remember the name though.
Do they have it available?
Yeah, it's in the house.
Can I see it?
Sure. So methadone. So what is methadone? Synthetic opioid used to help with cessation. This is another agent that's super, super long acting. And that's why it can be dangerous and fall into that category of one pill that can kill for these little kids. And when I say long acting, I mean really long acting. The half-life, so the time it takes for it to go down to 50% in your body, can be up to 55 hours. Yeah. So because it's so long acting, you might get a delayed presentation as well. Maybe a kid ingested it earlier in the day, in the morning, it's taking their afternoon nap, and then that's kind of when it's starting to present itself. So like you guys cued in with immediately, classic opioid toxidrome, everything's down. With these kids, pay particular attention to respiratory depression, If you need to RSI them, then RSI them. You want to support their ventilation because this is going to severely depress it for a long time. These kids can also require a ton of naloxone. So like as an initial dose, you could give up to 10 milligrams. Oftentimes, if they come into the hospital, they're going to be put on a drip of naloxone. And think about it, just look at that half-life. I mean, they're going to be on it for days just to let their body metabolize. So if you have a high suspicion for opioid overdose in a pediatric ingestion, you give one Narcan, it doesn't do anything, go ahead and give another. These kids can require a lot. Otherwise, focus on ABCs with particularly focus on airway. Now, I did methadone in particular because methadone has a weird side effect related to EKGs. Does anyone know about that? Okay, so methadone is actually a medication that can prolong QTC. So with these kids, get an EKG. You can have prolonged QTC as a complication. If you need to, you can give MAG. Obviously, if you're in an unstable rhythm and you need to defibrillate, then you defibrillate. But just know that with methadone in particular, prolonged QTC can be a complication. Other medicines that have opioid-related chemicals in them, like Imodium, loperamide for diarrhea, can also present with prolonged QTC, even though they won't have any central nervous system effects like respiratory depression. And then lastly, methadone is one of the medications that oftentimes is given at a facility in a more controlled environment. But in the last several years, there have been various exemptions and carve-outs made for folks with methadone. I think this kind of started with the COVID pandemic to take the medication home. So don't be surprised if you see folks with this medication available at home too. And then lastly, we have another long nap, and it's another 2-year-old. And the vitals look suspiciously similar to the last case.
But this one's probably not going to be opiates.
Well, Dad has history of opioid use and recovery and hypertension, same as usual, but now Narcan does nothing.
What's his skin look like?
Skin?
Is he wet? Is he dry? Is he pale?
Yeah,
Red?
mildly pale, dry, not diaphoretic. Kid looks similar, sleepy. Pupils aren't as pinpoint. Any ideas?
Potential sedatives, benzos.
Yeah, you ask parents, they're like, oh, we've got no other sedatives in the house. I just have my methadone, which I have, locked up right here, and the kid didn't get into it. I also take something for hypertension. I don't remember what it is, but it's a really, really small dose, like 0.1 milligrams, so I wouldn't worry about that. No. So, this is clonidine. So clonidine is a blood pressure medication. There's some brand names up there. It's the idines. Guanfacine also acts with similar mechanism. So these are alpha-2 agonists. Completely different mechanism than opioids, but they mimic the opioid toxidrome. So everything's down. You can see larger kind of relative bradycardia and hypotension compared to pediatric opioid ingestions, but you'll still get that similar CNS presentation. If you get called out for an opioid ingestion, Narcan's not working, or the story doesn't fit, or the kid doesn't have any access to opioid medications they could have accidentally taken, consider clonidine.
Isn't this sometimes used in, to help people get off of opioid dependence?
It's used as an adjunct. Can be used as an adjunct inpatient, yeah. But it's most commonly prescribed as blood pressure medication. So in terms of treatment, again, ABCs, ABCs, ABCs. If they're hypotensive, give them crystalloid. If that doesn't work, vasopressors. If they're bradycardic, give them atropine. The thing to know, again, is that Narcan won't always be effective. Sometimes you can get a response, but it won't always be effective. And then the other thing, if you have any suspicion clonidine's involved, just know these kids are going to be in the hospital for a really long time. I think the immediate release tablets of clonidine still last like 12 hours. So, and that's for the immediate release. All right, so to summarize, we went over several different classes of high-risk medications, a lot of blood pressure medications, including beta blockers, calcium channel blockers, alpha-2 agonists. We talked about digoxin, salicylates, including salicylates in weird stuff like oil of wintergreen, and some of the oral hypoglycemics. All of these are particularly high risk for pediatric patients and can fall into that category of single pills that can kill. You may get called out for something else, but just keep in the back of your head, hey, is there a possibility this is a toxic ingestion? Especially for those kids under 5 where they might just be exploring and putting stuff in their mouth. Presentations may vary. Somebody may present and look like an opioid overdose and have clonidine. You might get a call out for sepsis because somebody's hyperthermic, breathing, coughing, and has a fever and they ingested salicylates. So you got to be a little careful. But at the end of the day, don't overcomplicate it. All of these agents are going to cause weird things to happen with vital signs. Just support your ABCs. I'd encourage you guys, if there's any suspicion of tox stuff, not that you're not doing this anyway, but look at the BGL, look at an EKG, because those might give you important clues about what's going on. And beware of complications. Those are my references. Thank you guys for letting me speak to you today. Appreciate the time.